What's up, Gestalt Education Nation? Today's episode is brought to you by the Payday Practice and our good friends Jeff Langmaid and Jason Deach.
So how would Seth Godin, Gary Vee, and Tim Ferriss create a chiropractic practice? The answer is in this book right here. So our good friends Jeff Langmaid and Jason Deach, they created the Payday Practice to basically show you how you cover your monthly expenses in one day every month. Guaranteed. Generating monthly recurring revenue in your practice can create financial freedom, eliminate chronic financial stress, and turn the first day of each month from damn, it's time to start over to payday.
Get a free copy today at www.thepaydaypractice.com. The Payday Practice will show you the exact step-by-step process that you can use to generate monthly recurring revenue in your practice. Get your free copy today at www.thepaydaypractice.com.
All right, everyone. Welcome to another episode of the Gestalt Education Show. Today, just Brett and I on another solo episode, another solo adventure. So this has actually been a topic that we've been asked quite a bit by our listeners. We've been lucky enough to sit down with a ton of just amazing MDT instructors, Brett. Mm-hmm. People like Herbawi, Miller, like all these awesome people. And so we've had some chiropractors and some other people kind of ask our opinion on it and kind of how we integrate it into our office. And so I thought that would be a great topic for today. So Brett, I heard you kind of coin the term silent derangement quite a while ago. And so do you want to just like kind of tell us where that came from and then kind of, where MDT first kind of started into your treatment?
Right. Well, I think the first thing is, if you look at the actual derangement definition in MDT, and it's changed a little bit, but one of the components is to have a derangement, you got to have movement obstruction. Mm-hmm. So for those of us who are utilizing manipulation, movement obstruction to us basically means joint blockage. So by definition, you can take what we find in our joint play findings, and then we can automatically kind of bucket that into the derangement classifications. Now, there's some little nuances as far as terminology and things like that, but by and large, are the same things. So those of us who are used to like having more of like a holistic kinetic chain approach, then we're wondering, can we take the principles that are being used in MDT and can we apply that to a patient, even if we don't have radicular symptoms and even if we don't have some major episode of pain going on? Because a lot of times in the world of MDT, a lot of it is subjectively asking the patient about their pain. So, the thing that I've definitely wrestled with a lot in my mind is, as I've kind of gotten away from, treatment of pain per se and more in the functional route, could we take some of those like main tenets and pillars of MDT and can we apply it to this more holistic kinetic chain of approach? And I know that we can do that. The question is, how do we do it well and how do we give it the right verbiage and how do we not bastardize what has been, the gift of McKinsey? So, and I would just say that the gift of McKinsey, but also the gift of MPI, like those two really work well together as far as, because if you joint play a joint and we determine the plane of motion and it's not moving well, we're going to manipulate it at in range. And then we can send them home with McKinsey exercise because those are also going to be at in range. Mm-hmm. So you can keep it real clean and just think that if you're going to take the time to joint play it, manipulate it, why not send them home with something to be able to, keep that, the range of motion of the joint playing the joint. Now, those in a DNS and rehab camp, they're gonna be saying right now, well, what about what originally got us to this point? And trust me, we get that, and we have that built into the model. We just feel like, especially like when you're starting off in a treatment plan, this works perfectly. And I would just go back too from the people in a functional neurology camp, who is better off for having a joint blockage? You can be whatever camp you want, but at the end of the day, we know from a neurologic standpoint, from a neurophysiologic standpoint, that you're not going to be better off by having joints that don't move, period. Like we can debate, for the next 100 years on like how we got to that point and things like that. But at the end of the day, most of the people on here are utilizing some form of manipulation. Manipulation works on moving joints that are stiff. So we can take the principles of MDT and we can apply it to that. Now, your direct question was, the term silent derangement. Why we like that term is somebody could theoretically walk into your office, have no complaint, but we could still put them in the MDT hospital as far as like some of their great in-range exercise, as we're also implementing our other treatment techniques without us needing to bend them in a certain direction 200 times. So I guess what this is culminated in is you could take what you find in your joint play. Let's use a real life example, CT junction, okay? The patient comes in, they have, 4 segments in their upper thoracic spine that aren't moving well. Let's say it's extension. We can feel it at in range with palpation. Those of you who listened to me talk in the last 5 years know that's a huge thing that, I'm a big fan of. If you want to be good at joint play, learn how to palpate joints at its very endish range. Then it's hard to miss it. It's easy to feel, especially the big joint blockages. So then you could take that patient, we could manipulate them, we could, restore that motion, and then we could send them home with like a real simple retraction exercise. Therefore, we're able to start the process of getting some motion into the CT junction with home exercise. But I think that there's a lot of clinical gold in MDT that isn't utilized because we kind of think that, one, we got to have a patient that usually for most people that be listening to us, they're waiting for that patient to have radicular pain, So I don't think that needs to be the case. And there's a lot to offer our patients in this world of MDT that maybe not many people are talking about.
All right. I think there's a good scenario too. I mean, how many times do we have, let's say, a flexion responder in the cervical spine? Spinal stenosis, kind of, typical spinal stenosis, more arm pain than neck pain, respond to flexion, but the reason they have the stenosis is because they have that upper cervical joint blockage. So, or upper thoracic joint blockage. And so you may be using flexion as, almost like an analgesic early on to find the directional preference to centralize them. But if you're not thinking about the whole case, then that upper thoracic blockage is probably the reason that they're in the first place.
Yeah. And that's actually a really good point. So one thing, the case that jumps out is like IVF stenosis, where like you're doing some kind of closing procedure, perhaps you're making their arm symptoms kind of bark a little bit, but they need upper thoracic extension. So then like what I've really gone to, and I know you have too, is, we may use like extension in the treatment room, knowing we might start peripheralizing a little bit, but then we finish with flexion. So then like over the treatment plan, what we're basically doing is we're recovering the extension. And then we're also like for the symptom relief, as you said, we're now opening the canals and we're still giving them a way to get relief as we're recovering function, if you will, in that upper CT junction. Because what'll happen is if you just flex that patient there, from a functional standpoint, they have a really powerful tool to relieve their symptoms, but they actually a lot of times really don't get themselves better because we haven't like recovered the function there. So you might actually be using 2 directions at one time. And then obviously the order that you do that in the treatment is really important. Yes. Not surprisingly, we'll do the extension first and then the flexion second in that example. But so I mean, that's, once for those of you who are MDT certified, I think you got to know what all the ground rules are originally to play the game. And then we always kind of liken it to a wiffle ball game. If you play wiffle ball on your home field, like you have your own rules. Like if it hits off the gutter at your house and it's a not ground rule double, so then you get to kind of like change the rules a little bit. And we don't mean that to bastardize McKinsey by any means. We're basically saying this, wow, this wonderful technique system is so beautifully used even in the patient that may come in and not having a complaint. I mean, especially in the world of the athletic world, my gosh. Like I think like MDT is so underutilized in that group of people that it is purely insane. And again, we're back to what we already know about McKinsey. People think they know it all because they know 10 press ups, and there's more to McKinsey than being able to do 10 press ups. There's a lot of miracles by doing 10 press ups, but there's more to it.
Right. And then even going back to your athletic thing, what about your pitcher that's throwing today that's got a joint blockage in their midfoot that maybe you be using in-range dorsiflexion in order to recover that, or that could be the long-term strategy for them to continue to maintain their joint range of motion.
Well, I mean, I think that's too like where like something like MPI has such a role, because like you may in MDT like be dorsiflexing and not knowing the exact segment that potentially needs that dorsiflexion. If we talk about dorsiflexion of the foot, obviously you have 26 bones, 28 bones, depending on who you read, and 55 joints. So we have a lot of joints that are contributing to these motions. But when we talk about ankle dorsiflexion or dorsiflexion, we always just think it's a talocrural joint. So But if you know how to joint play, then you could get, whether it's Mulligan you're trained in or whatever it might be, you can get a lot more specific, or Gary Gray would be another great example of that. You can be a lot more specific to the exact segment that you're trying to go after. But if you don't have the ability to joint play, then you do have to literally bend somebody 200 times in a direction to see whether or not it's going to change their symptoms or not. So at the end of the day, joint play is, again, I guess you can get a lot of people better without knowing it, but I think it gives you access to a whole different set of things that you wouldn't if you didn't have that skill.
I think for two, it breeds a lot of confidence. Like sometimes it's not always clear. You're getting yellow lights and yellow lights and yellow lights, but if the joint play is changing, the soft tissues around the joints are changing, and maybe their symptoms are maybe they're centralizing a little bit, but maybe they're not. Being able to come back and feel like this is all getting better. Like this is the right route. Continue, versus you may be thinking about jumping ship earlier if you don't have that ability to kind of come back and use those audits.
Oh, yeah. And we talked about that in, I think, a couple podcasts ago about that black hole patient. You didn't get a McKinsey miracle. They're not going to surgery. Well, what do we do in between there? That doesn't mean we have to abandon MDT principles there. Like we can still be searching for their direction, but we can still be doing exactly what we just talked about, like in a way of recovering function as we're starting to add in maybe traditional rehabilitation, maybe strength and conditioning, DNS, whatever you're into. But yeah, I think that's a really important point. And again, it's going to highlight the importance of knowing what tool to use at the right time. And we're going to continue to harp on that because, again, that is what's separating great clinicians from everybody else. And that doesn't always get exposed because somebody could go, to, a different type of service. Let's just use the joint as an example. And, they may get a similar response as you, depending on, what case it is. But we're talking about like some of these nuanced cases that they've been everywhere. No one else can get better. That is requiring like a real specific skill set, and that that's not a knock by any means on the joint. It's just a different model, kind of different service.
Absolutely.
Not in a bad way.
And then I think it takes us back too of this integration piece of combining two of our favorite things, MDT and MPI. If you're not familiar with those two, MDT is Mechanical Diagnosis and Therapy. It comes from the McKinsey Institute, and MPI is Motion Palpation Institute. I just feel like those are good to define early on, but then those are part of our core four, Brett, because the assessments are so good and they can I would say it'd be hard pressed to find a case that you're not using at least those two together. It's kind of our bread and butter. We always say that DNS is the lens that we look at everything through. And then MDT, MPI, and neurodynamics are kind of like the adjuncts of the hands-on piece that kind of gives you what you need to do.
Yeah, because really, if you know those four things, then you can walk into any room and assess and get that patient better. If you don't have one of those four, then there's a patient today you can't see,
right.
Or you might not have a tool to get better. So then like then that next layer down, and we're not leaving out all the other things we think are important because like we are huge fans of all the different soft tissue techniques and dry needling, the functional med, all of that is of course important. But for us, and as far as like musculoskeletal rehab and manual therapy, those four have stood the test of time as far as an assessment and allows us to treat. And then one thing that I'm really intrigued with, and we're working hard on here with Gestalt, is like the integration between those four. I think there is, honestly, that's probably the future of Gestalt,
Absolutely.
So, yeah.
Maybe, Brett, let's go through, you've got a new patient today. Can you maybe just kind of talk through your thought process on your initial exam? Like where does joint play kind of start? Where does it end? Kind of just walk us through what you think.
Well, since one, I'm a chiropractor, so I guess I do have a bias, but if for no other reason, just to practice my joint play, I'm just in the habit of joint playing everything. So like if I have a new patient today, I'm not going to say I'm going to literally joint play every joint, but I'm going to definitely joint play all the major joints. And that can be done literally in 2 minutes, like if you have the right routine that Corey and I talk a lot about, like having kind of a palpation routine that you do over and over again allows you to really then, get good at that skill. So I'm going to joint play everything. I think like you just cannot deny the fact on the research of directional preference. I don't know what the new number is. I mean, as a couple of years ago, they used to say in the McKinsey world that there was 61 papers supporting the concept of directional preference, which means when you walk into the treatment room, no matter what your philosophy is, you owe it to the patient to see if they have a directional preference. And then you can, dangle crystals over them. You can smoke marijuana with them. You can do rehab. You can do whatever you want with them after that. But you really owe it to the patient to see if they have that miracle available to them in their life, because it can be that life-changing. And they say, like, when they look at the data, the derangement classification could be as high as 60%. Wow. So whether it's the spine or the extremity. So the first thing I always do is like, am I overlooking low-hanging fruit? Like, so is there a directional preference? I'm going to do a really good job of like trying to see that. So we're going to manipulate in that area. We're going to see if there's a directional preference. In the back of my mind, I'm also got my DNS hat on, and I'm wanting to see, like, is this joint blocked because, the patient's central nervous system isn't using the muscles right around that joint? Or do I think this is more of a peripheral nerve entrapment? Do I need to do a couple neurodynamic tests to see whether or not, a muscle's hanging this up, or is it a nerve root in the spine? All those are at play on day one to kind of see. And I mean, honestly, like we said maybe 4 podcasts ago, I'm going to walk into that treatment room. The first thing I'm going to do is I'm going to try to establish rapport. Like, one, does this person trust me? Do I convey certainty? Do I, am I commanding of their condition? And I think that would be the first thing. And then I'm starting to kind of sort myself through. I don't overpromise. A really good rule of thumb in life would be to underpromise, over deliver. And if you think what chiropractors do, they actually do the opposite.
Sure. Right.
Yeah. So they overpromise and underdeliver. So, we know with this skill set that we're going to walk in, and I mean, let's just say 90 out of 100 times, you're going to have a great outcome. Like 2 out of 100, you're going to have either a difficult personality or a difficult case. And I mean, those just kind of get flushed out with the numbers. But anyways, for the most part, that at this point, I don't put pressure on myself like I used to. I mean, like when I was your age, I would like just feel all the pain of these patients, like, and the pressure of trying to get people better in a visit or two. Now I've just kind of learned, if I want to do this long term, I can't take that all on. I'm just going to walk in. I'm going to do the best job I can in everything we just talked about, and I'm going to let the sand fall where it may, as they say. So, and that really is helped me out a lot once I start taking that pressure off me, because that is a recipe to burnout. And that's also a recipe to not getting good results, honestly, because you're trying so hard to change their pain that you kind of like forget about the whole functional thing, and that you're wasting time at that point.
Absolutely. Perfect. Well, let's go back to silent derangement just for a minute.
Yeah.
So I think for me too, I think that this is a huge benefit for our plea for seeing your patients more often.
Right.
Good
point.
So if we have a patient that we've gone through, let's say this acute derangement phase, they're 100% out of pain, they're on their way of changing function. Maybe you're seeing them monthly. Where does that fit into I know that you're a huge proponent of that, but maybe can you speak on, where that comes in for those patients that are coming back to see you?
Yeah. I mean, I just think like for the evidence-based group, which we're all in, the biggest fault that's happening there is gross undertreatment, right? So we'll start with that. So then you got to give yourself enough visits to be successful. But like, let's just say that, somebody is they're through all their pain. They're coming back to you. We're 3 weeks into this and they're like, I'm 100% better. Their function's quite a bit better. What does that look like in the future for the case? And I actually, 2 people that, that we've had one on the podcast that said, we should be in the musculoskeletal world, that being Gray Cook, be checking up with our patients from a musculoskeletal standpoint. He's, of course, the FMS developer and the SMFA developer. And then we have Shirley Sarman, also another physical therapist. So 2 people that a lot of people would probably be surprised to think that they're saying, we need to do like checkups like we would be like a cardiologist or whatever. And that's just what I think of. The other thing, I've been at this long enough and I've just failed with people enough to know, like, if I don't stay in their life, there's a very good chance that they can fall off. One, because it's human nature. They quit doing their exercises, let's just say, or they do something else, they get busy. So if I'm bolted in their life and I can just convince them of that, I mean, not to get all cheesy, but I mean, the point that I'm trying to make is like, really the biggest asset that you have in your life is not your house, not your car. It's literally your body. So like, I kind of think of myself as like, I'm the person who's in charge of your musculoskeletal system. So if you're not willing to give me 15 minutes of your life every month, then we need to reprioritize your life probably. So, and not everyone's going to be on board for that, but that's like the thought that I want them to have. So to your question, so then I'm, obviously I know the key areas that aren't moving well in their body. So, I mean, I'm using joint play now as an audit to come back to. So in that patient, this happens all the time. They're 100% better, but they still have stiff joints. They still have muscles that aren't doing exactly what we want them to do. So then that's what I continue to work on throughout their life. Once I learned that I wasn't, just fixing everything. I thought I was, but the reality of that. Then a lot of these people, we just are managing their case, So, and I think when sold right, it's a great model. And as long as you're, ethical and doing it the right way, people will be clamoring for it.
Well, and I think something that Herbawi said to me early on, one of the first times we ever saw him, is that the first sign of an impending derangement is range of motion loss.
Right.
And that is just a very simple way of, imagine your construction worker that's out there swinging a hammer all day long. To think that he's not getting restrictions in his spine and his extremities that could be down the road a big flare up. You're out of your mind. And that's literally what I tell my patients. Like, dude, I know that you're not going to do these exercises every single day. I know that you're not going to start eating healthy. You're not going to start smoking cigarettes or work out and stuff like that. So like, your insurance policy is checking in with me to make sure that you're doing your exercises, to make sure that these parts of your body are moving and functioning well. And then, hopefully when you do have another flare up, it's shorter and it's not going to take you out for a week like it did for this one.
Well, I think in the philosophical thing that everybody wrestles with is the whole self-efficacy piece. So the expert back in my day was a PhD by the name of David Linton. So he basically was, the first one who was really kind of beating the biopsychosocial drum. Craig Liebenson also. And so I think like what we all wrestle with is, well, should we be fixing people in 2 or 3 visits? That patient's out there. And and I have nothing against people who are doing that. I think like if we're honest with ourselves and you've been at it long enough, you're going to see that treating dysfunctional areas of people's bodies is a little bit more complicated than people think. You got your low hanging fruit and your miracles, but then like, if we study like conditions, low back pain is a great one. Like people who have a low back episode, typically they'll have other low back episodes. So you need to get over yourself to think that like you're fixing that person, because that can happen, but that's not the usual scenario, So when the wheels do fall off of that wagon, like, are you there to help them through that? Or like you said, like usually before catastrophic joint problems, low back included, there is a moment 2 weeks before where you're already feeling a little bit wonky. You might be doing a deadlift. You're like, oh, that didn't feel great. And then you have your major episode. So, if we can be there to help them through it. And I think like they can still be responsible for their problem. This is what the big take home point. They can still come to you and be treated, and they don't have to be addicted to you. Right. That's like a key thing that I think is so important. Like we still believe in self-efficacy. Our patients are still, we want them working out. We want them eating well. We want them doing the home exercise. That's all in place.
Absolutely.
But you also need a check-in. Like, like think about all the things in life when people go to counseling or whatever. Like you don't just go one time, or gym's a great example, a gym membership. You don't just go one time, oh my God, everything's perfect. Yeah. No, you have check-ins to help these people through their life and through their different ailments.
And you're not a sleazeball for doing that.
Nobody in our town, I hope not, thinks that we're over treating them or anything like that. It's the opposite. They appreciate that we're looking after that for them.
Right.
What that means though is you can't just walk in, do a bunch of blind random adjustments and then walk out and call that any kind of like maintenance wellness. To give a shout out to Kevin Christie, he uses a term I really like. He uses the term performance care. I like that because I don't like maintenance. I don't like wellness, but that's kind of the terms we're kind of stuck with, but I kind of like performance care.
Yeah, that's good. Yeah. I like it. Yeah. I just think the more we can do for our patients, the better. And from our standpoint, from you as a business owner standpoint, it's great to have people on your schedule like that. Like that is a great way to.
It's a win-win. That's not the reason you do it, but that's the other added benefit to it. And some people just don't like. they can't like play the inner game with themselves of seeing someone who's not hurting. Like for the mental side of that, you just got to change something in that visit today.
Yeah.
What is it? Joint blockage, trigger point? Like that's the game you're playing. Like you just got to continue to make those things better. And then I think show the patient that they're better. That can be like through an MDT movement examination. That can be through joint play. Like Lynn Fay's really good at educating, like feel how this feels different now, all these things. But I do think like a patient needs to know why they're there. If they don't know that, it gets stale and they'll end up falling off.
Exactly. I love it. Great conversation. I think like the term silent derangement, I just love that. Our patients don't,
they don't even know
they
what
don't give a crap.
is.
But I think for ourselves too, I mean, just continue seeking and destroying those areas of their bodies that aren't moving well. I mean, you can say all the fancy things, motion is lotion and all those dumb things. But at the end of the day, I mean, our body and our joints were meant to move in 3 planes of motion. And if they're not, then you're robbing, Peter to pay Paul. At some point, there's going to be something else that's going on. So
at the end of the day, we actually all have the same playbook. That would be any chiro, ATC, or physical therapist who's doing what we do. So the playbook is basically this: joint play, trigger points, muscle length, tone, maybe like your neurologic test, deep tendon reflexes, things like that. So that's the game we're playing here. So who can do the best job of changing those 5 or 6 things? And that's why the core 4 are the core 4. We feel like those 4 things are giving the best results to change those things. And therefore right now it's producing the best results in the world. So I mean, that's plastic. I mean, that can always change, We're definitely not married to that, but I think like whoever does the best job of integrating all those things together, the results are scary, honestly. Right. It's unreal. Like once I personally kind of started understanding like how to put these stuff together, like, I mean, it was an epiphany moment in my life and career, just because so much so to where like, like if somebody's not responding the way that you want, I mean, it's going to basically expose you're dealing with, that chronic pain classification, which is out there, or you're dealing with something structural that potentially you're not going to help. And we might need the help of our orthopedic friends. But I think hold yourself accountable to a trial of care that it can be that good to where you know your outcome kind of.
I love it.
Yeah.
Bro, we got a bunch of travel coming up, so I thought I'd keep people interested. So we got some cool stuff. We got some great opportunities, some podcasts that we've been searching after for a while coming up that we're definitely excited about. But next weekend, we're in Tennessee. So you're speaking at the Tennessee Chiropractic Association on DNS.
Yep.
So that'll be great. And Murfreesboro, I don't know how to say that word.
That is a ton.
I don't know. And then we got a really good podcast set up there. And then we're heading to Pittsburgh. So we got a couple of good podcasts there that week. But then as far as courses we got coming up, I wanted to kind of give a shout out to explain DNS Pediatrics, which is in September 9, 10, 11. So we had a little bit of a date change there, and we had an instructor change. And so our good friend Marcella, unfortunately, is dealing with some medical issues and unable to travel. But now we have Martina coming.
Oh, she's amazing too.
Yeah, so I'm so excited. Obviously, Marcella is close to our heart, and we hope she gets better and stuff like that. But we're really lucky that Martina had a free weekend and was willing to do it. The other great opportunity for this is normally a 4-day course. We're going to break it down to 3 days. And so it's going to be long days, but this allows you to not have to miss another day of treatment in the clinic and to come really learn it. I always tell people, honestly, I don't treat a ton of kids and I don't love it, but DNS Pediatrics is where it all kind of made sense to me. That's where it really all started to make sense of this whole piece of DNS, mainly because it's a deep dive into ontogenesis, deep dive into neuro. I mean, it's the first time that I really was like, holy crap, I understand this now. And so not that the other courses are bad or anything. It's just like this to me was the stepping stone. And you don't need any previous experience or anything like that. And so we'd love to have you here in Troy. It's a great weekend.
Sometimes like if you go to an exercise 1, you're kind of led to believe, unfortunately, like that DNS is just a bunch of like baby exercises. Then you like go to a pediatric course or something like that and you're like, whoa, this is like looking out into the ocean. There is so many layers to this technique system if you want to go there. The other thing, we have a big Tmj seminar coming up. So
yeah, that's the weekend after.
Yeah. So that is, we've just implemented so many different things in that. And I'm really proud of that because that's kind of been my pet project for the last 20 years. And I think that is, not to be a homer, I think it's the best one going by far.
By far. The other thing too is it's in depth. I mean, it's not just how to manipulate the jaw and stuff like that. So there's a lot more stuff to the jaw.
And then I feel like a lot of people that are teaching this, Taylor, they one, they don't have the experience to be teaching it, or two, they just don't see the cases of it like that. Some other people have. So I mean, you talk about it can be a little bit algorithmic in this area. However, when you run up into a roadblock, you got to know what to do. Because in that area, like if you make the wrong decision, you give a bad back adjustment, they'll get over it. You do the wrong thing in the jaw. The jaw.
It's the most unstable joint in the body, right?
You got to be careful. You got to be very careful. What else? In neurodynamics.
Neurodynamics. Yeah, that was a huge ad last minute. So that's going to be in October. So October 7, 8, 9. Same thing. This is usually a 4-day course, but Michael Shacklock has done a hybrid version. And so this is actually going to cover the upper and lower extremity, which is kind of crazy. And so again, you would normally it would be 8 total days to do the upper and lower extremity. And so this is
He's been locked up for 3 years over there with COVID. So, I mean, he'll be ready to go.
And so that's going to be an awesome opportunity. And then we're kind of excited. I'm a homer for this next one coming up in October, the Cleveland Centennial.
Yeah.
So 100 years at Cleveland University. So Dr. Cleveland was nice enough to welcome us both. We're going to be teaching some manipulation there. Sean White's going to be there, the snowboarder. And
who's he?
Yeah, exactly. So that, and then we got some great MPI courses coming too.
So Justathon's coming up. Oh, we got Gary Gray for MPI.
MPI Gate the last weekend in October. So there's a lot of stuff going on. September, October for us is going to be crazy. So
if you were wanting to sit around and watch football this fall, we're going to make it hard for you.
That's right. So if you guys know any good divorce attorneys too, so we may need one. Hopefully our wives are listening. So, but anyway, guys, I just want to take this opportunity to kind of tell you what we got coming up, and follow us on socials for some action, because I'm sure that through these travels we'll have some good content.
And then the podcast coming up, we've outdone ourselves coming up here. So.
We'll start teasing a little bit on those in the next couple of weeks, but it's. We thought we hit it with James Andrews and all those types of things, and now we just keep outdoing ourselves. I'm pretty proud of that. So, anyway, guys, make sure to check out our sponsors. The Payday Practice, and then also Core 360 Belt. We still have our deal with Core 360 Belt. Use the code Gestalt for 10% off on all the belts, and we look forward to hearing from you next week. All right.
Yep. Thank you.
Have a good one. I hope you enjoyed this episode of the Gestalt Education Show. If you liked it, share it, subscribe to it, send it to your friends, send it to someone that needs to hear this message. We really want everyone to be able to tune in and get the best clinical advice that they can, which we're hoping that we're giving to you with these special guests. So if you have any questions, please feel free to reach out to us, or if you have any suggestions on upcoming conversations, let us know. For a list of our upcoming courses, we're adding them all the dang time. So go to gestaltedu.com, click on courses, and they'll all be right there for you. All right, have a good day.